Good morning, and welcome to our session, Bridging Decision Science and Clinical Guidelines for Better Care. My name is Cynthia Chude, and I'll be your moderator for this session. In today's complex clinical environment, practice guidelines are more important and more scrutinized than ever. They are intended to standardize care, reduce error, and improve outcomes. Yet, the gap between guideline recommendations and real-world implementation remains wide. In this section, we explore how tools from decision science, ranging from cost effectiveness to constraint optimization, and to the integration of patient and clinician preferences can help close this gap. We'll walk through 3 themes today. Model 1 on cost effectiveness, Model 2, optimization, and Model 3, preferences. Together, we will work to provide insights on how these tools can improve the guidelines we rely on and the outcomes our patients experience. Let's begin with Model 1, cost effectiveness, presented by Dr. Amy Cizik, who brings deep expertise in surgical outcomes, guideline development, and economic evaluation.
All right, good morning, everyone. Before we get started, who are the clinicians in the room? Who are the practicing? Oh, all right, great. And do you mind me, can you shout out your areas, your fields? Oh, yay. What we do? Great. Dale, did you hear that? We got a pediatrician. All right, well, great. So yeah, I think this is an experiment. We're hoping to gain not consent. You didn't consent to be a part of the experiment? Okay. Well, feedback that this was a good session, hopefully, or not good. We want to know. All right. Let's see. Let me get my slides ready. Here we go. All right. And just by way of background, so I mostly do surgical outcomes research. I do a lot with patient-reported outcome measurement, PROMIS specifically, but trained as a health economist and did my share of modeling. I don't do it as much anymore, but this was really actually a great exercise to understand. I definitely come at it more from the clinical practice guideline development piece of it, and then taking all the things that we do here in terms of clinical decision-making and cost effectiveness and understanding. Does modeling help? How can we help each other do better? All right, so for those of you who are familiar with clinical practice guidelines or not, the definition for they are statements that include recommendations intended to optimize patient care. They're informed by systematic review of evidence and an assessment of the benefits and harms of alternative care options. And I think what I really want everyone to remember from my talk is this part of the definition that talks about alternative care options. And thinking about comparators when we, what are we really comparing as the alternatives to make the decision? And in order to develop a clinical practice guideline, these guidelines need to meet these 8 standards of trustworthiness. And I was pleasantly surprised. The orthopedic one we were going to review did all of this work. They did a really nice job in making sure they established transparency, management of conflict, guideline development, group composition, so who was involved in the guideline development, thorough review of the literature, and rating the strength of that literature, and then articulating recommendations, and then providing an external review to their members, and then proceeding and checking in on these guidelines and updating them. So again, for those of you who have never been to the Society for Medical Decision-Making or not as familiar with cost effectiveness, we anchor cost effectiveness, and I think of it in the broader term of value-based healthcare. And this is how we define value, quality plus service plus access over cost. And I've defined what we mean by those terms. But cost effectiveness kind of reverses that. So when we think of cost effectiveness, typically we model things using an incremental cost effectiveness ratio. And we compare 2 things. We compare intervention A to intervention B. And we look at the numerator and the cost difference between those two, and then we have some sort of measure of effectiveness. And that effectiveness measure can be measured various ways. So the most familiar is cost utility analysis, and we use QALYs to do that. But you could also do it based on other types of measures, such as implant survival or blood pressure reduced between two options, or days at home. One treatment offers you longer days at home. So there's many ways to look at the effectiveness piece. So the other important thing when we're thinking about cost effectiveness is framing the problem. So what is the decision, and in what context are we making that decision? And so the viewpoint or the perspective depends, again, on who's making the decision or who's sponsoring the project. And so often we say the societal perspective is a gold standard of cost effectiveness. And we include cost when we do that, such as travel to get the intervention, or the childcare that needs to be provided, or the days of work loss to do the intervention. So societal takes into account all the things that go into receiving or getting that treatment. But there are other types of perspectives too. There's the patient alone and has nothing to do with the hospital or the system. The system has a perspective on the costs it takes to bring in supplies and things like that. So perspective's a big part of when we do these type of analyses, how we set them up and frame them from both the cost, more so the cost than the effectiveness piece. And then lastly, the time horizon. So you'll hear the term time horizon, and that could be within 1 year or 5 years, or if it's spine surgery, 7 to 10 years. So the time horizon can also help us determine whether something is or is not cost effective, and at what time point is it cost effective. So I'm going to give you a case study or an example in total hip arthroplasty. I've been in orthopedic surgery for about 20 years now. First was at the University of Washington, now at the University of Utah. And this is one of the best things orthopedic surgeons do and improves quality of life, is total hip arthroplasty. But there's a lot of decisions that go into doing that. So the way they set up their guidelines is kind of the overall management of osteoarthritis of the hip. And they looked at various types. Oh no, my arrows. I was a little worried about that. Oh gosh. Shoot. There are arrows going up and down in each direction, and I don't know if I can see those somewhere else. Do I have time to pull out my computer? What do we think? Well, we'll go through these. It was whether the, how strong it was. Anyway, we'll move on. All right, so the first one was tranexamic acid. This is for bleeding, and the quality of evidence was high, and the strength of the recommendation was strong. And then we also have the recommendation for postoperative physical therapy. Again, the quality of evidence was high, but the strength of the recommendation was moderate and downgraded. And it's interesting because I think a lot of patients do go and get their total hip surgery and think they're automatically going to be referred to physical therapy. And that is not always the case. And then physical therapy is a conservative treatment. We have corticoinjection steroids, hyaluronic acid, management using NSAIDs. And where I want to spend a little bit of time or think about is this, what I thought we would get into the guidelines is the decision to have surgery or not, and is it cost effective? Surprise, surprise, that is not in their recommendations. That is not the comparator. And so that's probably the biggest takeaway that I hope those that are physicians in the room, but even those of us that do this work, is hoping to guide the types of decisions that people probably really care about. And when they go and see a surgeon, they're trying to decide between whether to have surgery or not. But that was not in this recommendation. So the only surgical things that they did look at and compare for cost effectiveness was cemented versus cementless femoral fixation. And the quality of the evidence was very low, but the recommendation they had enough evidence to make was moderate. And again, that could be from the hospital perspective, right? What type of supplies do we stock? Is it more cost effective to have this versus that? And then exposure approach. So whether you expose from the transverse or the lateral side versus an anterior approach. I need to move on. The arrows worked here. There we go. Yay. So again, these same different recommendations, none of them compared surgical to non-surgical treatment. And you can see the cost effectiveness evidence in various capacities. Some of it was limited, some of it was high, and you can see whether cost increased or decreased and what type of quality of life adjusted years people had from these various treatments. So if we were to think about ignoring the economic constraints of these clinical practice guidelines, what might happen, or what are some things that would happen if we didn't include this perspective? So for corticosteroid injections, they are recommended based on clinical benefit, but the guideline does admit that there's limited comparative data on their cost effectiveness. So again, they don't have the right comparator or the one they quite want. And in order to do this, they didn't really account for the costly imaging guidance. What it takes to actually give one of these injections. So again, this gets into this idea of perspective and including all costs. Post-operative physical therapy was the one evidence they had was presented as unsupervised exercise, so remote, and we know not everybody has access to that. But it concedes that cost-benefit analysis haven't really also been conducted, but they used it in their cost-effectiveness study. And again, cemented versus cementless. There's a clear difference in cost between these. The training needs to do these two type of procedures and the complication rates. But if you really dig deep and look at the studies that they used for this, they note cost effectiveness as complex. So they kind of wash over it. And they felt that the insight there wasn't really actionable insight, or they also didn't propose, well, what would make this decision better? So there's that trade-off on the economic side. And then for the clinical practice and for the physicians in the room, the comment is, well, it oversimplifies clinical complexity, right? That's why you're physicians, you're in the room, you're making decisions. Each patient is its own individual with a different story. And so when you think about when we do these cost effectiveness analyses, they are framed around average outcomes, right? The average age with the average comorbidities and an average functional status, or a functional status that we know led people to even be offered surgery. They don't acknowledge the types of access to facilities. So again, if PT is recommended, but people live in rural areas with no PT, that could be a problem. And socioeconomic disparities, right? So again, it was acknowledged that these things exist, but they weren't integrated into the recommendations. What do you do if your patient has X, Y, or Z? So clinical practice guidelines are great, but they can oversimplify to a one-size-fits-all approach. And obviously, this can lead to not cost-effective care. So this kind of tees into one of my partners who's going to talk about constrained optimization and how that can help, and what are things we can do as modelers to have better evidence and provide better studies, and to tailor these things so that the recommendations can reflect that. And so you could see here that there were notes made in the clinical practice guidelines. Cementless might be preferred in younger active patients, even though cemented decreases costs and implant costs. There is a hospital cost. But again, if you have an older patient, maybe that's the more appropriate decision to make. And so I want to move along, but kind of where do we go from here? So now that you know what cost effectiveness is, and how do we merge these two and do better? So I always think this is my family, my parents, my two children. And so why should clinicians care about decision science? Well, it does provide the societal perspective, and the idea is that we're fully informing members of the community to make good decisions with the best information that we have. We know that you as clinicians are the clear expert on clinical and survival outcomes. But it's really hard for you to be an effective agent of the patient or caregiver in front of you. They know their preferences and what they want. And so we have to think of better ways to make those decisions together. So how can we work together? And this is the crosstalk part. And this was a really fun exercise because Lou Garrison was my senior advisor on my PhD. So it was awesome to see that he had published this. Have we reached a tipping point? And professional clinical societies have attempted to define value and consider it in their deliberations about appropriate care. But we do know the US has not been routinely or explicitly wanting to know the value or cost of things. And it's very hard in our market here in the US to know the actual cost of things. We have insurers and middle people, and it's very, very challenging to understand that. Also, traditional medical education does not, at least in the US, does not address value, right? Again, you are taught to offer whatever treatment your mentor offers, and there's no thought to really the cost or the value of that intervention. And there's, from societal perspectives, when developing clinical practice guidelines, there is always this issue of conflict of interest and who's recommending it. But the recommendation is that all guidelines should include cost effectiveness to improve objectivity around what's being recommended. So I've gone over my time. These are our key issues and challenges in thinking about blending these two areas, and welcome discussion later on. We've already really talked about this, but what should guidelines include that optimize these things? And Dale will get into that next. So I'll turn it over.
Great. So thank you, Dr. Cizik. We're now transitioning to constraint optimization, presented by Dr. Bayoumi, whose work has shaped health policy in Canada and beyond.
Thank you, Cynthia. I'm a decision scientist, and I'm also a clinician. I'm a general internist in Canada. So I want to talk about the implementation of guidelines. So I want to move away from developing guidelines and really think about how guidelines are used and if they're used. And I particularly want to talk about constraint optimization as a way of addressing some of the problems of implementation. So perhaps not surprising, guideline implementation can be challenging. As Amy was just saying, the goals of guidelines tend to be to enhance quality of care, to make care consistent, to reduce preventable errors. But we have lots of literature that the use and implementation of guidelines is often quite limited. Here's one example. In Spain, of 21 primary care centers, patients with cardiovascular disease, they had 438 patients that they identified, and yet only about 39% were receiving guideline-recommended drug therapies. And there are many, many studies like this. Excuse me. So we can identify that people don't get guideline concordant therapy. So the next question, obviously, is what are the barriers to that? And there have been several systematic reviews now of this topic. And here's just one results from one review. All of them have come to more or less the same conclusions. Sometimes there are 6 circles, sometimes there are 5, but I just chose this one for illustrative purposes. So I won't go through all of these, but you can see that the big categories are political and social context, health organizational and system context, clinical practice guideline context, health professions context, and the patient context. And some of my co-panelists have discussed some of these issues already. I'm going to select 3 topics from each of these categories that I've listed in red here, and I'm going to talk about those in a little bit more detail for the rest of my talk. So I'm going to talk about adapting guidelines to local contexts, about limitations of infrastructure, and about difficulties in prioritization. And let's start by just having an example of each of those 3 categories that I'd outlined in red. So the example I chose for limitations of infrastructure are about acute stroke management. So this is an example from 2017. For the clinicians in the audience, I do want to recognize that stroke management has changed in the last 8 years. So I'm not saying that what I have here represents optimal stroke management, but the purpose here is to really think about what guidelines at that time said was optimal management. They said stroke care should be delivered in specialist units, so there should be acute stroke units in hospitals. That patients who are eligible for reperfusion therapy should get it and get it expeditiously. That aspirin should be administered within 48 hours, and that decompressive surgery, so actually surgery to relieve pressure on the brain, if it was indicated, should be available and offered to patients. But uptake of these has been low, like as we said in other contexts. But I did actually want to also point out that as an international society, we should also be thinking about uptake in countries that have different levels of resources. And there was a very interesting study from Ghana that said that only 3% of patients in Ghana get care that is concordant with these guidelines. Well, and again, people have looked at what the actual barriers are, and the barriers here are mostly about infrastructure. How do you actually marshal resources or allocate resources to meet these infrastructural demands? So there's often limited staff capacity, workload demands, physical space for stroke units, lack of stroke beds, financial resources, access to CT scans or other imaging. So all of these infrastructural constraints. And how do we optimize a budget in order to be able to have as many people as possible achieve those guidelines within those constraints. Second example I want to give relates to difficulties in prioritization. And I want you to imagine this is back in late 2020. Of course, we're all experiencing the COVID-19 pandemic at that time. In Canada, where I'm from, the Health Canada, which is the federal agency, the ministry, said that the goal of pandemic response is to minimize serious illness and death while minimizing societal disruption. And their guidelines actually recommended that vaccinations be offered in 3 stages. I'm just going to show you stage 1 here. So stage 1 was residents and staff of congregate settings, adults who were over 80 years old, and then after that, those were all vaccinated, adults over 70 years old, frontline health workers, and adults in Indigenous communities. And so I put this up really to highlight that last section about adults in Indigenous communities, and I want you also to pay attention to that phrase about minimizing social disruption. Okay? So here again was an agency trying to determine how to allocate resources, but their objective wasn't only to minimize deaths from COVID-19 or even minimize infections from COVID-19. It was also to address some societal inequities, some historical societal inequities. Right? So this idea that there are multiple objectives and there is a need for prioritization within those objectives. And then I want to talk about my last example is customizing guidelines to local contexts. So people have defined different aspects of customization. Adaptation addresses implementation issues, whereas contextualization, talks about changing aspects of guidelines for the local environment. So an example of local customization might be changing clinic workflows. So if guidelines say that so many patients should be seen, or the average wait time for a patient should be below a certain minimum, local customization would be about changing clinic workflows in order to meet those guidelines. Whereas regional customization might be something that occurs at a higher level. And the example I chose here is about pre-exposure prophylaxis for HIV in Estonia. So the authorities in Estonia were thinking about what drugs and which populations to recommend should receive pre-exposure prophylaxis. They had the WHO guidelines. They looked at what other countries were doing. They didn't actually adopt the WHO guidelines as written. They adapted them for the local context. So they had a slightly different target population, and they ended up actually recommending a different drug than what was recommended in the WHO guidelines. And then lastly, the WHO guidelines recommended that in breakthrough infections, so people who are on prophylaxis but nevertheless got infection, The WHO guidelines said there was no need, or it was not a good investment of resources to test them to see if the virus that they were harboring had resistance, whereas in Estonia, they decided to actually go ahead and recommend viral resistance for breakthrough cases routinely. So I'm going to take a step back and just talk about a method, and the method I want to focus on, which is constrained optimization. It's a method from decision science. Its goal is to maximize a well-defined objective or objectives, often through deciding how to allocate resources. The objectives can be clinical, so it might be something like patient satisfaction. It could be administrative. It might be something like wait times. It could be financial, so it could be related to costs, or it could be other categories. And then there are constraints to that implementation. And constrained optimization really asks, what's the optimal allocation of those resources to meet those objectives? I didn't put the reference here, but we have a tutorial that was published in MDM last year about this as well, if you're interested in the mechanics of how to do this. So I want to take those three examples that I just presented to you, and I want to reframe them as optimization questions. Okay? So the first is remember about the stroke units. So if we were looking at this as an optimization question, we might ask, what's the optimal allocation of space, access to imaging, and staff resources within the acute stroke unit to maximize the number of people with acute stroke injury who get timely reperfusion therapy? Okay? So we've defined our variables that we're going to change. We've defined our objective. We've defined our constraints, which here are limits of space and money. The second one is which patient groups should be vaccinated first in the context of a new rapidly spreading infection to minimize the number of people who are hospitalized or die, and how are equity concerns addressed. The third would be how can clinic workflow be optimized to minimize patient wait times through hiring new staff. The fourth would be how should HIV prevention technologies be invested within a fixed budget to minimize the number of new infections. So, to go back to the method and just break it down a little bit, the elements of mathematical optimization I've put here over 2 slides. The first is really the objective function, which is what asks what is the goal of the analysis. So the goal might be to minimize the number of COVID-19 deaths. It might be to maximize the number of stroke patients who get treated, who get reperfusion therapy. But there has to be a well-defined objective. There are constraints, which are the limits on those decision variables. A very common constraint, for example, would be a budget, right? So as clinicians, as a manager in a unit, you might be given a fixed budget and say you can do whatever you can within that budget, but you can't exceed that budget. Then there are the decision variables. These are the unknown quantities. These are the things that we change in the model in order to achieve the outcome. So it might be the number of visits to a primary care clinic. And then the parameters are the actual data for the problem. These are the numerical values. It could be something like the number of available vaccines. So I'm just going to show you a few published examples of optimization to show you that people actually do this in real life. And sometimes it's actually used for decision making. So this was a paper by Isabel Rao and Margaret Brando, 2 of our society members, that looked at the sequential allocation of vaccines to control an infectious disease, right? And you see here, I'm taking one sentence from each of these abstracts just for illustrative purposes. They considered 4 objectives, right? We talked about defining objectives. So here they defined their objectives: minimize new infections, minimize deaths, minimize life years lost, minimize quality adjusted life years lost due to death. Of course, in Canada, we added the objective of ensuring that people of Indigenous ancestry also get prioritized. Here's an example by Ben Lung and Timothy Chan as a senior author. They looked at optimizing the placement of public access naloxone kits using geospatial analysis. So they said they took the city of Vancouver, which has a large number of overdoses due to opioids, and they said if there were publicly distributed naloxone kits, where should they be located in order to minimize the number of overdoses? You can see optimization-based strategic placement of naloxone kits at transit stops yielded generally higher coverage levels. Opioid poisoning is covered with 10 kits compared to 1,000 kit locations. And here's an example from MDM Policy and Practice by Bjorn Berg and colleagues that looked at balancing provider schedules in outpatient specialty clinics. And their conclusion was the constrained optimization schedules used 100% of the available clinic time compared to the reference scenario schedule where 87 to 92% or 82 to 90% of the clinic time is being used. So a way of actually maximizing flow through for clinics. So Amy just talked about cost effectiveness analysis. And there might be some obvious parallels, right? But so it's worth taking just a second to say, how is this different from cost effectiveness analysis? Both analyses can consider costs. Current optimization doesn't have to consider costs, but it almost always does in the context of decision making in a resource environment. Cost effectiveness analysis rarely incorporates a budget constraint. Right? So when I was on a committee that recommended whether drugs should go on a formulary or not, we looked at cost effectiveness, we looked at budget impact, but we rarely treated that budget impact as a constraint. We just sort of said, what's this going to do to the budget, to the provincial budget? Customization, if it happens, usually happens at a macro or national level, and it's sometimes considered as distributional analysis. There's a lot of interest, of course, if you've been at the meeting for the last few days, of distributional cost effectiveness analysis. But rarely considers things other than distribution. Whereas constrained optimization, the budget constraint is typically explicit. It more readily, I think, lends itself to customization, particularly at the meso level, so at the institutional level, or at the micro level, which is the individual clinic level. And it can incorporate many other constraints or objectives besides just cost, qualities, and life years. What are some of the challenges? First, there can be multiple objectives and trade-offs. So as a clinician, you might be, if you're a clinician or even if you go to a clinician, you're aware that patient care often looks to seek improve multiple objectives. And sometimes these are competing objectives. What happens when decision variables go in opposite directions? What happens when we give stroke patients medication to dissolve clots? There might be better outcomes in terms of the stroke, but also more bleeds. How do we combine those multiple objectives into a single objective function? How do we quantify the trade-offs? So clinicians often do this implicitly. Optimization, like many other decision models, requires this to be explicit. The second is, we talked that one of the strengths is customization, but customization is also a challenge. If we think about how do we apply optimization at the clinic or hospital level, the challenges here often are related to data needs. The need to have parameters that are relevant at the local level rather than just borrowing parameters from other settings. What do we do when data is not available? Do we look to the literature? Do we look to similar sites? Do we rely on expert opinion? And each of those options has its limitations. And then third are some conceptual issues, right? Some concepts may not be readily adaptable to an optimization framework, like equity. Is equity an objective? Do we look to decrease disparity between groups? Do we prioritize historically marginalized groups? Is it a constraint? Do we ensure that no groups go untreated? Do we ensure that each group gets a minimum level? My friend Lauren Cipriano reminded me that oftentimes you can reframe objectives to be constraints and vice versa. Right? But it probably matters also in terms of the framing for people who are actually the consumers of the analysis, not just for the people who are producing the analysis. Similarly, we can look at quality of life. Should it be integrated with survival, like in cost effectiveness analysis, where we talk about qualities, or should the trade-off be made explicit? And how are these quantified? So I've been talking about this like it's a great thing, but important to recognize that there are some things it doesn't do, right? It'll never be a replacement for deliberation. It's like any decision-making tool, it is a input into deliberation, it's not a replacement. It can't address issues that can't be quantified, such as some ethical concerns. It won't address non-optimization related barriers to implementation. So many clinicians feel according to the literature, that guidelines are in front to their personal autonomy in terms of how they want to practice. Optimization won't address that. And sometimes problems are so complex that they won't actually find a solution. So that might require reframing the question, or it might require finding approximate solutions or other approaches, but not every problem can always be constructed as an optimization. So some concluding thoughts. Constrained optimization can help to address some of the issues related to suboptimal implementation of guidelines. In particular, can inform issues related to constrained resources, such as money, space, and staff. It may be particularly helpful at the meso or micro level. It's an opportunity, I think, for more clinician-analyst crosstalk. And lastly, I just want to say I think it's still underused. It's still used relatively infrequently, including in health services research, even including in our society. And I think really an opportunity for both clinicians and analysts to increase, and a way to increase their cooperation and conversation. Thank you.
Great, thank you, Dr. Bayoumi. And lastly, we'll transition to preferences presented by Dr. Steele. He's an accomplished pediatrics emergency physician and statistician.
So at least I'm old. My daughter says I'm an old grumpy white guy who doesn't like to be told what to do. I'm not a competent statistician, but a little statistical training is dangerous because it makes you more skeptical and exposes you to things that you believed, not believing them so much. Well, as I was thinking of this, as I was making the first draft of the slides, I had ordered something via Amazon, which has made a great deal of money by doing things like constrained optimization. It was raining, and as usual, the package arrived on the porch without the cover, without the roof, as opposed to the easier to get to porch with the roof. So it reminded me that all of these things have impacts, and they have impacts in the clinical setting. So I wanted to just sort of kind of naively talk through an area that I'm not an expert at, but which I do several times a shift. So this picture is to remind you that not all babies are babies. This was the group picture after a particularly productive academic year with our faculty and fellows. This big, robust creature who's upside down on the top would actually not be part of this guideline because she's 3 or 4 months old, and if she had a fever, we'd say, well, she probably has a virus. Come back in 4 days. If she has persistent fever, we might look at a urine. Some of these other babies, I'm surprised their parents let them, participate in this group. It was pre-COVID, so different world. One of the things I have had the pleasure of doing is participating in systematic reviews and occasionally meta-analyses. And I wanted to just sort of talk about some of the sort of issues with the process of guideline development. In some perfect world, there's a very comprehensive systematic review, multiple databases, a priori review protocol, and then a document is created over a year and a half. And in this case, this was an evidence report, so shorter than some systematic reviews, 297 pages, including appendices and references on this on the topic that I want to talk about, which is the diagnosis, mostly diagnosis and management of febrile infants. So you'll notice that this was 2012. It was well written. It incorporated papers I knew about, and couldn't do a quantitative synthesis. They might have been able to do a quantitative synthesis had they had individual patient data, but that is really still not happening in medicine. One wishes that this had been done 10 years later, because often systematic reviews are begun when something is sort of hot and the studies are underway or have been presented in abstract. But I think we forget that it takes 2 or 3 years for these actually to appear in print and to be available for systematic review. So an argument for live systematic reviews and long-term funding, sort of wishful thinking in the current environment. One of those important studies that happened, this was 2019, was a large prospective cohort of patients where patients were enrolled and multiple features were identified. Tests were done based on a protocol, and then they used a greedy tree-based model. You can think you can start at the top of the tree, it's sort of an upside-down tree. 9% or so of these kids had a serious bacterial illness, meaning urinary tract infection, bacteremia, or meningitis, or some combination of the above. Many of them have a urinary tract infection, so that gets you to that right-hand leaf, which they don't really define what low risk is, but certainly 49% is probably high risk, but possibly less severe than certainly meningitis. So continuing down the tree, the way the algorithm works is it's greedy in the sense that it picks the best predictor, moves down, picks another predictor, moves down. So if you look at the individual leaves, there's, if your absolute neutrophil count, which is sort of a reflection of the infection-fighting cells in the blood, is elevated, that gets you to 6%. Arguably still high-ish risk. And then we have a new biomarker called procalcitonin, not really new, but new to many of us, that if that's low, you can define a leaf with at least in this study, with these assumptions, with a rate of 0.2% of serious bacterial illnesses. So in my part of the world, there's a lot of discussion about rules and not very many discussions about models. And if you start talking about models, people sort of roll their eyes and lose interest. So what my residents do almost routinely before I get a crack at talking to them about the patient is they'll go to the internet and they'll search CHOP, febrile infant algorithm, common search. The other one is MD Calc. And so in this case, you have a patient with a negative urinalysis, ANC of greater than 4,000, and a normal procalcitonin, low risk. But the harder case, and I think we would all agree that that's an advance because we used to admit all of these patients, treat them all with empiric antibiotics, and really expose a bunch of babies with colds to unnecessary interventions and treatment. So this was a paper I should have written a letter to the editor about, and I think it will cause some consternation in members of this society. So this was an argument for the 2x2 table, and it's held out. The title implies that it's a methodologic standard that output of some rules is just a probability, of a given diagnosis, leaving clinicians to decide how to act according to this knowledge. Oh my gosh, we have to think. Although this may be acceptable in certain clinical situations, rules that fail to provide clinicians with clear direction may not achieve widespread adoption. That may be true. And because they do not remove the uncertainty that created the need for the rule. That was the problem, the thing I felt particularly problematic. And as I've gotten older, I don't know what to do about uncertainty. I used to think that I tried to deal gracefully with uncertainty. Now I just sort of tell parents, we're going to learn some things and we're going to muddle through. I think in clinical practice, that's the best you can often do. So finally, 2021, years have passed. Many of these studies have been published in abstract form. A pretty ambitious clinical practice guideline came out from the American Academy of Pediatrics. I wasn't on the committee. I've never participated in such a committee. Note that it's 38 pages long. There are multiple tables, multiple graphs, sort of in that same tree-based format, and some appendices and some parenthetic things to worry about. One of the things they did, and it'll become obvious when you look at how this, at the downside impact of this, was that they now had multiple studies. They didn't really have the time or the methodologists to do a formal meta-analysis, but they had sort of personal data, and they took these, well-designed prospective trials, and they sort of threw them all together, and then they came up with kind of reasonable but tough to show that they were accurate rules. I hope nobody in this audience was on that committee. So that came out, and then depending, many academic institutions, if you go to Google and Google, clinical prediction clinical guidelines. CHOP has a good set. Seattle has a good set. The usual players: Cincinnati, Yale Children's. This is the note the cute dolphin in the upper corner. This is our attempt at one of these subsets. So 29 to 59 days old. I think that always troubles me. That like this, what happens if you're 28 days old or 60 days old? In any case, now the rule at our place is any inflammatory marker, and so height of fever got thrown in that pot. We can't currently measure procalcitonin, so they substituted and picked a threshold for C-reactive protein, urinalysis, and then shared decision making makes its appearance. We'll talk a little bit about that more. But there are many decisions, but some of them are: how do we obtain the urine? Do we catheterize the baby? Do we stick a needle in his bladder through the skin? Or do we put a bag on, so forth? Do we do a lumbar puncture? That's a big one. We'll talk a bit about that. Do we treat presumptively? And do we admit to the hospital or discharge? So along the lines of grumpy old men, this is an article by somebody I don't know in the sort of emergency medicine gray literature, and who says some things that resonate a little bit. Like, what began as a tool has ballooned into a crutch that threatens to replace the practice of medicine itself. Protocols have become the rule, not the guide, and foster a dangerous mindset where blind adherence is favored over thoughtful consideration. One size fits all cannot possibly account for the nuanced presentations of disease, and that emergency departments in particular will become conveyor belts of impersonal care, churning out treatments that may be correct according to the protocol, but wholly inadequate for the individual. I agree with some of these things. I think the part that bothers me the most is the critical thinking part. I think if you have a prescriptive algorithm, it does, I watch my train, I think this is the exception rather than the rule. And in an era where many of our children are cared for by mid-level providers, nurse practitioners, and others who have not gone to medical school, this is an even bigger issue. So I said I had a master's in statistics. One of the things that resonated with me was a now old textbook by Frank Harrell, who said that classification is an arbitrary forced choice. And reading the clinical literature, particularly the AI literature, many of these decisions are framed as classification problems rather than prediction problems. That bothers me. And he would say, use the full information in the data to develop a probability model, then develop rules based on the estimated probabilities. That's not what is often happening. So going back to that landmark paper from the Pecarn group, buried in the methods section, indeed, there's a quote: "We prioritize the sensitivity of the prediction rule by specifying a relative cost of 100 to 1 for failure to identify an SPI versus incorrectly predicting SPI." Many of you probably know how to do that in a thoughtful way. This was just, it's sort of reasonable. Maybe they polled people, but I don't know. What if it's 200? Or what if it differs depending on the invasive bacterial infection, meningitis versus UTI? It certainly does. I don't really need to talk a lot about dichotomization and the problems with it to this group. It's still rampant, and I think it's part of the problem. So are there other better options than decision trees, which are, to the naive clinician, are very easy to read, sort of give you a little bit of information? This is one of my favorite current tools. This different patient population, these are toddlers primarily and infants with fever and possibility of UTI. So this is a website from the University of Pittsburgh. Click on, enter the features here. There's still some dichotomization. Of note, this actually one of the variables actually used to be race, and Black race was protective. That was sort of problematic because I think many people had a hard time understanding that from a causal perspective. And, one of the cool things is I think they got a lot of heat about that, obviously, and they changed it. They replaced duration of fever and history of UTI, which made a lot more sort of causal sense. A couple of things to notice about this approach. I'm not sure my residents go to this naturally, is one, you can do sort of a clinical, you can play what if games. Like, what if that sniffle really isn't another fever source? What if the fever that the mom said felt hot was lower or higher? You can sort of do a clinical sensitivity analysis. One of the things that bothers me is the level of precision that's presented down there. So this is one of the problems with logistic models. Unless you do fancy bootstrapping and stuff, you have this precision, which is sort of doesn't reflect the true variation in the estimate. And they've also, I thought this is interesting. In the prior iteration, I used to ignore this because I'm a grumpy old man who doesn't want to be told what to do. Now it used to say if the predicted probability was 2%, you should obtain urine. Now it says, well, they try to address my quibble about accuracy, about precision, and they say, well, your patient's probably between 2 and 5%. You should do shared decision making. So that's entered our language. And then they give you this sort of the population level estimate, which is, probably the 2x2 table. I just parenthetically, I'll mention that during COVID, when people weren't leaving their homes and when pediatricians weren't seeing patients in person, I changed my threshold. I'm not sure if that was rational, but I did more testing because I wasn't sure I would get these kids back. And there are some patients who are easy to get back and some patients who are not. So I'm almost embarrassed to put this slide up now after listening to several days of thoughtful people talking about shared decision making. So we take this, as we're muddling through these cases, we sometimes have people who really don't want that lumbar puncture. It was one of the reasons I have a beard was, when I was 27, I was not very persuasive with a baby face. Now I should probably shave the beard off. The peak effectiveness of the beard was at about 45, and it's decreased ever since. So we're risk averse as clinicians, and if you live long enough, you see the bad effects. You see the occasional patient with meningitis who you sure wish you had figured out the first time you saw them. You see the patient with renal scarring and you wonder if you treated them a few days earlier. So we have this is our current, as of today, if you know the website to go to, what we're told to do in our ED. So if you can't convince them to do, to let us do a lumbar puncture on your child, then you should be more conservative. That makes sense. But in essence, what we're doing is we're presenting them with the choice of, well, let us do this, or we're going to admit your baby to the hospital that we might otherwise be able to send home. And for many of our patients, it's really the admission costs, missed work, childcare, loss of sleep, that is the real cost in this sort of decision. One of the great things about this crowd is there are people who actually talk to patients and do qualitative assessments of what the patients are thinking about. And this is I don't know if this is a particularly good example, but it turns out that one of the big drivers of refusal is fear of paralysis. I've done lots of stupid things in my career and had many failures, but I've never seen a baby paralyzed from an LP. But that is way high on the sort of thought minds of parents. And then I think there's more and more distrust of physicians and our motives, and particularly when we wheel a computer over and make them sign in 3 places for something that probably objectively has a side effect profile similar to things that we don't make them sign for. So how can decision science help? I think we have clearly moved from here's how we do it here in Philadelphia or Boston, or those were, by the way, the 2 sort of paradigms. There was the Boston Children's Way and there was the CHOP Way, to rules, which is, I think, where we're at now, to how to use multivariable prediction models in a way that makes sense to clinicians, that allows them to learn from these pathways, protocols, rather than following them blindly. Certainly, we have access to the web. I wish I could say that the EHR used all the computing power that was available to it, but it's very difficult to add these things, at least to our EPIC instance. Clinical decision support is, maybe that's what this, these guidelines are. And then I think we're very early. We've begun to talk in emergency medicine about shared decision making. I'm not sure we routinely do it. I'm not sure that it's many times it's like, we don't know what to do, so like have the parents help us make the decision. Or they don't want to do what we want to do, so how do we get to some kind of a reasonable option? I think there's lots to be gained. I think in my setting that you don't have a relationship with these people. This is not mostly emergent in the sense of needing to make a decision immediately. It's a familiar thing, so I think there's time and room for improvement. That's all I got. Thanks.
Okay, so thank you all for being a part of this section. I think over the past hour, we've seen how decision science offers more than theoretical value. It provides concrete, actionable frameworks for making our clinical guidelines smarter, more patient-centered, and better aligned with real-world constraints. And a couple things that stood out in these models that I wanted you guys to keep in mind as we close up is, first, the need for multidisciplinary collaborations between clinicians, modelers, economists, and patients to build guidelines that reflect both data and lived experiences. Second, the importance of contextualization, recognizing that one-size-fits-all recommendations often fail in diverse and under-resourced environments. And finally, the value of transparency in decision-making, showing the assumptions, trade-offs, and values behind guideline recommendations that invoke trust, uptake, and ultimately patient outcomes. So on the behalf of Dr. Bayoumi, Cizik, and Steele, we thank you and are open to some questions.
Uwe Siebert from UMid Tyrol and Harvard University. Thank you so much for bringing this important topic to the table. I have one question that is related to the benefit-harm trade-off when we use these decision trees or models, decision models. Being in several guideline committees, I've seen, Ahmed, your situation that people have constrained resources. I'm not talking about cost effectiveness, but we don't even have enough vaccines and so on, or enough sites. And I've also seen the other, Dale, what you showed. We now have to make an individual decision. For example, when do we, how often do we screen? Where's the optimal cutoff for sensitivity and specificity on an ROC curve? And you showed this wonderful example that there is that implicit trade-off. I'm willing to accept 100 to get 1. And this is where we sometimes sneak in with modeling. I'm called in a guideline to do cost effectiveness study. I'm saying, okay, we do a Markov model and something like that. But don't call my chapter cost effectiveness, call it benefit, harm, cost trade-off or something. And my question would be, how can we be more successful? Because many of the guidelines are not interested in cost effectiveness, but they are interested in looking at which threshold should we do something. And usually the answer is, oh, we need 85% of sensitivity, or look at the prevalence. At that age, there is a kink, right? But maybe the optimal threshold is before or after the kink. So maybe you pick one of you. How can we improve our influence without, being just called as cost effectiveness modelers, to optimize the benefit-harm trade-offs, which is the first thing that physicians should do in a clinical guideline, even if they ignore costs.
I'm not the physician. I mean, I was going to ask the physicians on the panel and also in the audience, because my comment is it's too statisticky, right? And so I think this is where Dale, what drew you to better understand or want to know statistics to be able to do these things. And I think to Ahmed's point too, I mean, the other comment I thought, and then I want the clinic, this is not my question, but is here in the US, right? Cost effectiveness is kind of a dirty word. And so I think we're making some headway when we call it value-based healthcare. And we're starting, although recently, I don't know what's going to happen, but at least in hip arthroplasty, right? We do have to now have outcomes, patient-reported outcome measurement. And if we do not report those at baseline in 1 year, there is loss of funding to the hospital for that. That's called the CMS Pro PM bundle. And potentially by next year, there will be a threshold for substantial clinical benefit that will also roll out with that data collection. So I think, again, the US is slow to this, but people are warming up to it because there's just not enough to go. We have to start resource constraining things, but I'll open it up to my colleagues.
I was just going to say, I can see how there might be an optimal threshold in the population, but at the level of interacting with a specific patient, I think you can make a strong case that there is no such thing as an optimal threshold, and the threshold depends on the clinical situation at hand. I mean, these are very nuanced. One of the things that I didn't talk about is that we always have other information. Some of it is related to equity or lack of equity and concerns about follow-up. Some of it is the that thing called the physical exam, which is harder to incorporate into a decision tree. In one prior iteration of this, I made a valiant effort to include the social smile, which often happens around 6 weeks as a decision branch, and was, these things are done by committee, and the rest of the committee put the kibosh on that. So I don't have anything sensible to say. I think these panels of people, the good guideline panels include patients, parents, clinicians who are often experts, but it doesn't replace the interaction at the bedsides. Certainly, and I think there's this sense that, a methodologist is a methodologist is a methodologist for these guideline panels, and you can afford one. So hopefully methodologists will include things that we should all have Uwe as a methodologist.
So I just add two quick things. I think I entirely agree with that sentiment. And, I think if we ever had 100% implementation of a guideline, I would be really worried, right? The guidelines are just that, they're guidelines. So, this idea that there are cookbooks or recipes, there's been lots of literature on that. And that's, a lot of the reason that individual clinicians feel that they're intrusion on their own autonomy in terms of choice. But back to your question, one of the reasons I became interested in constrained optimization after having worked very long in cost effectiveness analysis is because It's back to that idea, even if we don't do a full constraint optimization, that idea of very clearly identifying what the objective function is, I think is something we still do poorly. It's incumbent, I think, for everybody who does a cost effectiveness analysis to realize that once you adopt the CEA framework, you are adopting also a value framework in terms of what it is that you're trying to optimize. And if that's not actually what the Clinical Practice Guideline Committee or the patients or the clinicians want to optimize, it's not going to be relevant. So I'm less concerned actually about the threshold for the decision making as I am concerned about actually constructing the question in a way that's relevant for the decision maker. And to me, the corollary of that is then it begs the question of who is the decision maker, which then opens up all sorts of conversation about including patients and families and communities in that framework, and also an even bigger question about values. So the objective function under a Republican administration might actually be quite different than under a Democratic administration, but that's why we have a pluralistic society, and we recognize that decisions might change over time, and that's okay. There isn't a constant value function that we should mandate that everybody accepts. So it gets messy, but that's the real world of decision making. But I do think going back to really clearly defining what the objective is something that many people sort of gloss over to their own detriment.
Mike Berry from Boston. Great session, lots of food for thought. Two quick things. One for Ahmed, and you mentioned the equity issue. I'll give the example of screening for lung cancer. So, low-dose CT, lots of randomized trial evidence. It's one cancer screening test that could reduce overall mortality, at least from the original report of NLST. And yet I learned recently that in the Indian Health Service in the United States, more appropriately the Indigenous American Health Service, but that's not what it's called, there's not a single low-dose CT scanner. People can correct me if things have changed, and of course, I'm in Boston where you can't throw a tomato without hitting a CT scanner. And over the short run, that's not having a CT scanner is a constraint, but it's so clearly an inequity, and it just somehow feels wrong to say, well, let's take that off the table and move on to something else that we have. And it just quickly for Dale, I thought your slide about the worry about paralysis being a kind of driving factor, and yet I bet a lot of those informed consent forms that you have people sign have death paralysis, right, from the hospital lawyers. So that's food for thought for how to share the decision and how to bring some information to what people are concerned about.
Yeah, Mike, I think we don't have time to talk about what equity means, but when I will say, I'm both encouraged by the inclusion of distributional cost effectiveness analysis in our society, and a little discouraged by it because it is a fairly specific and I think sometimes too narrow definition of equity. And so I think when we talk about resource distribution, assuming that we're starting from a normative allocation and then or normative distribution and allocating within that distribution, which is kind of what you're talking about in terms of the availability of CT scanners, is problematic, right? So, so even though I was talking about at the meso and micro level, I don't actually believe that those can be divorced from that macro level, and especially for a concept like equity, where we're talking about. I don't have an easy answer because there is no easy answer, but it doesn't need that broader perspective if we're going to think about what equity actually means.
So I'm going to bring it back to the previous discussion about the guidelines and the thresholds because I've actually thought a lot about this in the past year. There are 3 different problems that I apply this to, and it all kind of comes out with the same issue. The first one is around antibiotic use for community-acquired pneumonia, where you have to start empiric antibiotics before you know whether the patient has a bacterial infection or not. And there is a guideline from the Infectious Disease Society of America and the American Thoracic Society that changed what are sort of the recommendations for who should get empiric antibiotics that are broad spectrum, aimed at gram-negative organisms and MRSA. And we actually looked to see what impact did that have at a bunch of different hospitals. Not what it actually had, but if they had followed the guideline, how would it have changed their practice? And I don't think that the guideline committee considered that. I don't think that they thought, what is this going to do to the percentage of people who are going to get antibiotics? And how is this going to affect the percentage of patients with resistant infections who are not going to be covered by the appropriate antibiotic because of, if they follow this guideline? And I think that that's something that guideline committees need to consider. They didn't come anywhere close to sort of saying is, well, what is the probability threshold of a resistant organism at which you would want to use broad spectrum antibiotics? Because this is just so far from the way that most doctors think. And I think any of the doctors on the guideline committee, I don't think any of them think in that way. And depending on how you frame this question, I like that slide that you put up there where you said, on a population basis, this will pick up 95% of the infections or 90% of the infections. If you say to doctors, well, what probability of a resistant infection are you willing to tolerate? Which basically means you're not going to treat it, right? If you don't give them the antibiotic, you're saying it's okay not to treat this. What probability of that is okay? They're going to say 0, right? And they're not going to say 10%, 20%. On the other hand, if you say, what probability of an infection does a patient have to have before you would use these broad spectrum antibiotics, they might say 5%, 10%. Except if you go up to a probability of 5 or 10%, you're really going to miss 95% of the resistant infections. So people aren't thinking in this way, and depending on how you frame the question, you're going to get different answers. I think that we need decision analysts or people with this kind of training on the guideline committees. So how do we go about doing that?
I just want to comment. That was kind of my big takeaway in doing this is, again, for orthopedic hip surgery, there was no question or no decision not to have surgery, right? So I think it's that counterfactual, right? And I think for people in the field, there is, they're treating or doing the thing that they do, and to think of the correct or appropriate comparator, I think is difficult without outsiders, so to speak, or people who think about decision making being a part of that. So that's my 2 thoughts.
I was just going to make a possibly naive comment about equity. I think there are 2 sides to the coin. At the clinical level, there are people who aren't, for various reasons, going to be able to get the resource that they need, be that a CAT scan, an MRI. And so sometimes the appropriate response is to do more for people who have less. The flip side of the coin that I struggle with is this, for lack of a better word, entitlement. At least in US healthcare, if you come in and you want something and you articulate that persistently in a firm way, you're likely to get it. So some of the overtreatment and excess care actually is due to, for lack of a better word, entitlement, or the sense that you can and can afford and should get more treatment, even if it's not necessary in some sense.
So I just want to comment that, so Steve Downs was a decision analyst on the pediatric UTI committee in the 2000s. I was on the DDH committee for a while. At one point I said, in order to sell this guideline, we need to know what that 100 number is. What's the false positive? And they said, no, our job is to collect evidence, not to do new evidence collection. And so, so we did get decision models part of the clinical practice guidelines, but I think subsequently they were not they were not used afterwards. So it's a it's a sales job. Question I have: do we know? So, two things. And just one other thing. For 20 years, I asked residents at the Harriet Lane Clinic, "What's the lowest probability of meningitis for which you'd want your kid, or at least your niece or nephew, to get an LP?" And they said 1 in 1,000. Except for the lawyer, the woman who had been a lawyer before she was a resident, she said 1 in 1,000,000. So I said, "You're nuts." And then, but he said, but 1 in 1,000. So even 0.2% is above, but that was a UTI. But so even 0.1% of meningitis is high enough to get an LP by physicians. So, and our EHRs do not help us at all in distinguishing 0.1% from 1%. So another aspect is that we mentioned EPIC. We teach to informaticians that guidelines that guidelines is decision support. And I spend all my time trying to tell them how evil guidelines are, just to oppose that, and failing. But that's a really insidious thing that's going to happen is as we put everything more and more in the computer, we're going to actually encode. So let me just the question I have is, what is the proportion of patients who are not covered by guidelines? What do we think that number is? Do we have any good? You said there are many, many articles, but I haven't read them all. So what do we say that number? What's the approximate number?
Oh, for febrile infants, yeah. I mean, there are many sort of exceptions. One of the interesting ones in this most recent guidelines was, I have no idea why they decided it this way. They left 0 to 8 days out. I have a feeling it was a political issue with the neonatologists. If you appear ill to the clinician, if you're premature, if you've had prior antibiotics, if you have focal infection. So I think sometimes those exceptions become very important if you're focused on, let's just another sepsis workup. Those exceptions, and particularly relevant in this group, are the viral illnesses, which, the RSV infection can be much more deadly than the UTI in a 10-day-old, for example. So yeah, really interesting question. I think the question about meningitis is one that troubles me. Is we in pediatric emergency medicine, we often have sort of very low risk but catastrophic potential outcomes like meningitis, and I find it very hard to compare to think rationally about those risks.
Okay, thank you everyone. We really appreciate you coming.